Hello everyone, my name is Guolin. I come from Center for Joint Surgery, Southwest Hospital. The topic is called surgical transepicondylar axis. We identified accurately in preoperative 3D plan for total knee arthroplasty, a reproducibility study based on 3D CT. On the pictures are my two colleagues who concentrate most on this study, Dr. Lei and Dr. Liu. So equal extension and flexion gap is one of the key objectives of total knee arthroplasty to achieve satisfied soft tissue balancing. But femur component malrotation could be one of the most major causes of unbalanced flexion gap, so which will cause pain and knee stiffness. There are multiple lines referencing femur rotation during the surgery, and the transepicondylar line is one of the most important. During the surgery, if we can achieve a femoral component rotation parallel to the TEA, that could possibly lead to a good clinical result. But if we cannot put a femoral component parallel to a TEA, that could be a reason for unbalanced flexion gap and the patellofemoral mismatch. So during the surgery, we try to find the transepicondylar axis, but it is somehow difficult to accurately identify STEA by palpation of the bony prominence because of the poor vision and the soft tissue coverage. On the picture, we can see that there are multiple tendons and ligaments attached to the medial epicondylar, which makes the soft tissue very thick and hard to palpate the bony prominence. So this point of view has been echoed by many studies as shown here. So the divergence between STEA and the posterior condylar axis could be measured before the surgery from a CT tomographic image. And we have done this study help us to achieve a better femoral rotation position. In order to achieve better femoral component rotation and flexion gap, there are many ways, such as navigation, PSI, and the robotic surgery. But all of these methods also depend on identifying STEA on the 3D CT-based image. So the purpose of this study is to identify STEA on 3D mode. Although this does not break through the framework of defining STEA by recognizing bony prominence on the 3D model. Although soft tissue has been removed from the CT images, but still sometimes it's very hard to identify medial epicondylar. In this study, we use CT scans from 6 patients with 60 knees, and we identified STEA in 6 experienced total knee surgeons. They identify STEA 3 times independently with an interval of more than 15 days. A total of 18 STEA were marked for each 3D model of the knee joints, and the divergence between them were measured. So from this table 1, we can see that to evaluate reproducibility, the interclass correlation coefficients and their 95% confidence intervals were calculated, while the median IQR of overall intra-surgeon variation was 1 point. That's okay. But the maximum was up to 14 degrees. That means different surgeons who identify STEA on one femur, there could be a divergence of 14 degrees between them. Well, for the intra-surgeon variation, it was 1.2, but the maximum was 11 degrees. That means that even for the same surgeon who identify STEA on the same femur for 2 times, there could be a divergence of 11 degrees. So that is huge. This study also indicates that visibility of bony anatomical landmarks is positively correlated with the reproducibility of identifying STEA. The above four dynamic graphics to 3D knee model of number 6, 15, 29, and 56, respectively. Of them, the reproducibility of number 6 and 15 were poor. You can see the bony prominence is very obscure from the 3D model. There are multiple MR studies showed there are actually multi-rotating center for the femur during the full range of motion of the knee. And the divergence between the rotating center is very huge, over 15 degrees. The fact lies in the study that for femur rotation, there is femur rotation and the femur rotation to tibia during the full range of motion of the knee. Well, the green point means that the femur rotate in a single axis. Well, if you combine it with the rotation between the femur and the tibia, so the center could be swift from the green one to the red one. And there are multiple MR studies showing that during the full range of motion of the knee, the rotating center is shifting. Now, we have done a study many years ago to show that if we ignore the rotation between the femur and the tibia, the femoral component will be rotated with a single axis, as shown from the pictures. So there are multiple designs of total knee arthroplasty. The single radius, multi-radius, fixed bearing rotating prosthesis are not natural knee. Maybe the prosthesis rotate with the medial pivot rotating platform will be the most anatomic design of the total knee arthroplasty. So in conclusion, determining femoral component rotation is important for balanced gaps, especially in flexion. The identification of STEA intraoperatively or on a 3D model may not be reliable. We should be cautious when determining femoral component rotation by referencing STEA. The reason may lie in the fact that the natural knee flex by a two-axis motion mode, but we always try to describe it with one. Thank you very much.